Terrific. Well, good afternoon, everyone. Welcome to this session on left atrial appendage closure innovations, joined by esteemed colleagues. We've got Dr. Nadira Hamid, we've got Dr. Devi, Nair, we've got Dr. Jason Rogers, Dr. Muhamed Saric, Saibal Kar is unfortunately not here, Dr. Clifford Kavinsky, Dr. Nishtha Sodhi. So all-star group to share their experience and their cases. And we're going to kick off with the keynote given by Dr. Devi Nair, The Landscape of Left Atrial Appendage Closure Innovations. Thank you.
Thank you. Good afternoon, everyone. So I'm just going to take this out of here. I'm going to take it out of here. It's too close. All right, so these are my disclosures. And I'm one of the electrophysiologists, so I'm kind of left out in the crowd, but thank you for having me. You might see some maps in here, just curious. So just to start off, you know, the history of appendage closure starts as early as 1949, you know, with the first endocardial device going in 2001, which was Plato, and then some first generation Watchman and Amulet devices, and later on, the FDA-approved devices, both Watchman Flex and Amulet devices, followed by array of devices that were being tried, including some endovascular and epicardial approaches. So this has been going on for many years. The clinical evidence, what I'll do is go over some of the clinical evidence for what we have commercially available and then look at the future a little bit. So if you look at the clinical evidence for Watchman, you can see there's a large body of clinical trials that were performed as early as 2002 with the pilot studies, and then the Watchman 2.5 trials with Protect and Prevail, and then the Pinnacle Flex ID trial that looked at Watchman Flex device, which got its most recent approval. Now, the Watchman Flex device was definitely a big step up from the legacy device with its multiple strut frames and the dual anchors and the closed end that allows for a much safer and effective implant. And we saw those with the Pinnacle Flex ID trial, where we saw much safer implants with safety events as low as 0.5. And LA closure, complete LA closure at 90% at 1 year, and then very good procedural success and OAC discontinuation rates. We saw those results continue on at the 2 years as well, with very low annualized stroke rates of about 1.7%, very low DRT rate, still DRT was there at 1.8%, and no device embolizations noted in the clinical trial. Now, the second device that got commercial approval in the US is the Amulet device, which has a different set. It has a different mechanism of closure because it's a lobe and disc device. So it has a dual seal closure mechanism. And it also has a large body of clinical evidence. Majority of that evidence comes from Europe, but the largest body of clinical evidence in the US came from the Amulet IDE trial, which compared the Amulet device to the Watchman 2.5 device, which was a legacy device that was available at that time. And the trial, the device met all three primary endpoints and also non-inferiority in the secondary endpoints. But it did show that the device was probably superior in closure rates compared to the legacy device. Now, those results continued on until up to 3 years as well. And we saw that the annualized stroke rates at 3 years was still about 1.6%. Again, showing the value of appendage closure in these patients who are not tolerant to oral anticoagulation. Now, one of the largest clinical trials in the surgical field was LAAC 3, which looked at appendage closure in patients going in for cardiac surgery, randomized them to appendage closure versus non-appendage closure. And we saw there was about 42% reduction in stroke and systemic embolism in these patients who underwent appendage closure. Now, 75% of those patients also were on oral anticoagulation, so just to keep that in mind. But definitely, this is the largest body of surgical literature that we have in this field. PROG 17 was one of the trials from Europe that looked at appendage closure as first-line therapy. So the first look at LAAC versus OAC in patients who could actually tolerate oral anticoagulants. And it showed that appendage closure was not inferior to OAC in this trial of 400 patients. So where are we now, and what are the limitations, and why do we need to look more into the future? There are still technical issues. We still have to be pretty careful about device selection when it comes to LA anatomy. We still have to worry about periprocedural adverse events, whether it's effusions or trauma, whether it's embolization. And then we need better delivery systems in certain cases. We need to prevent things like air embolism. We need to prevent things like stroke during implant, and also post-implant peri-device leaks and DRT. We hear more and more about how these leaks matter. And so that's where the future is looking at. So let's look at what's in the future for clinical evidence. What other evidence are we generating here? Let's look at what is the future for workflow and maybe technology. So there's a lot of ongoing and upcoming clinical trials that are looking at multiple things. One, concomitant procedures. Now, is it feasible is one thing. Is it possible is another question. So option is a clinical trial that's looking at AF ablation in appendage closure. Watch TAVR and Watch Rhythm are other clinical trials that are looking at concomitant procedures that could potentially combine both LAAC and other similar procedures. Optimizing therapy, whether it's using ICE, whether it's optimizing post-implant regimen. So ICE LAA was just completed and got Watchman Flex ICE approval. So that's again being further looked at with 4D ICE. And then trials looking at appendage closure versus oral anticoagulation and use of appendage closure as first-line therapy. So Champion AF and Catalyst are probably the biggest trials in that arena, and some of the other trials listed. I'll quickly go over some of the bigger trials. Option trial, which finished enrollment, looked at appendage closure as first-line therapy post-AF ablation. So these patients could get their appendage closure at the time of AF ablation, so concomitantly or sequentially at 3 months after. And the patients were randomized to device and OAC group, and we'll have results of this trial in 2024. Champion AF is all comers, so looking at Watchman Flex versus oral anticoagulation in patients who have non-valvular atrial fibrillation and who are candidates for oral anticoagulation, so as first-line therapy. Large trial looking at 3,000 patients. It's completed enrollment and is awaiting results, probably results out in 2025. Catalyst is, again, the brother to Champion, Amulet versus OAC as first-line therapy, currently enrolling. So I encourage all of you, if you are a Catalyst site, to actively recruit in this trial. I think we'll have a lot of answers and a lot of data in this patient population. So how about technologies that can help? So pre-planning, especially with 2 devices commercially available and some of the future technologies coming in, I think it is important for us to pick the right device for the right patient. And some of these automated CT pre-planning softwares, such as Watchman TruePlan or FIOPS, these are different computational predictive modeling algorithms that allow us to pre-plan the procedure way ahead of when you're in the lab, so you can avoid surprises. So we did see PREDICT LAA results presented by Aldebacker showing improvement in efficiency and safety with these pre-planning techniques. How about optimizing inter-procedure imaging? So use of 4D ICE technology and even combining imaging and fluoroscopy and using Echo Navigator for implant of these devices and improving these inter-procedural imaging techniques. How about transeptal? I think the RF transeptal technology has come a long way. We have made these transeptal procedures and these LAC procedures quite seamless. And this is, again, advancing with other technologies coming down the pipeline. Steerable sheets, do we need them? There are certain anatomies where sometimes you can't really get a coaxial implant, and these might matter. And so on the Amulet side, you know, the Amplatzer steerable sheet was approved. Currently, it's not available. It's been redesigned. And then the next generation of the Watchman sheet, called the TrueSteer, is on its way, and it's going to allow for better coaxial implants and better tugs and better angiograms to prevent any kind of peri-device leaks and much more coaxial implants. So how about future generation of designs? So why do we need them? Now, of course, we currently have two devices, and we still have issues. I do believe that even though the implant success rates are pretty high in these clinical trials, the question is, are we getting these implants optimal? And are they optimal implants? Are we leaving leaks behind? Because our leak rates are pretty high when we look at these clinical trials. So there are multiple new technologies, both single lobe design, lobe and disc design, and also some special designs that we'll go over in the next few minutes. The Watchman Flex Pro is the next generation of the Watchman device that has a non-thrombogenic coating. It's called the Hemocoat coating that is, hopefully will prevent DRT. It also comes in a bigger size, so it's a 40 millimeter size for a bigger appendage, and also has these radiopaque markers that is going to help with more coaxial and optimal implants. Another device that's currently in clinical trials is the conformal device. This is a device that comes in two sizes, both regular and large, so a little less size agnostic. Has a compliant endoskeleton, so it conforms to the appendage, has an EPTFE covering, so hopefully will prevent DRT. It does not really have a metallic insert, so and just has those tethers, so hopefully we'll have less DRT and better conformability. Again, this is currently enrolling in its pivotal ID trial. The laminar device is a different technology that has a rotational LAAC closure mechanism. It has a little ball that goes into the appendage, twists the appendage closed, rotates the appendage closed, and locks it in place. Has a very low surface exposure of metal, so hopefully we'll have much better much better closure rates, hopefully no leaks, and very less DRT. So currently in the EFS trial, and we'll see more of that later in this session. CardioCorex and Append are two other technologies that are also currently not in the US, but making its way to the US. Again, looking at just strategies that could prevent implanting things in the appendage, leaving things behind in the appendage, and maybe even looking for concomitant procedures like AF ablation or appendage isolation. How about Amulet? The second generation of Amulet is currently in the making. Hopefully it'll be more conformable, have better anchors, because that's been one of the challenges with the Amulet device, and with the newer generation of the steerable sheath called the Intriga, which will have a four-way steerable mechanism. So in summary, there are multiple appendage closure devices available. They all have different safety and efficacy rates. There are multiple trials that are ongoing that are looking at optimizing therapy, looking at newer technologies, and also expanding treatable patient population. With that, I'll stop and take any questions.
Devi, that was fantastic, a whirlwind and comprehensive tour of the innovations landscape. And I apologize, I forgot to introduce Dr. Koulogiannis, but Costa, interested in your comments as an imager. Two-part question, what do you think has been the greatest innovation from your perspective on the imaging side, and where do you think is still yet the unmet need? And again, it's the imaging perspective that I'm interested in.
Okay, I'm live. Good, confirmed. Thank you, and thank you everyone for being here. That's a great question. There are multifaceted answer I think I could give to that. So, we use a combination of TE imaging. More and more, we're using intracardiac echo. I know, some of my esteemed colleagues here are very familiar with that. I think for each of those modalities, the increased comfort in the community and use of just live multi-planar reconstruction, I think has been has been a game changer in terms of procedural efficiency, but I think also in terms of results. We're fortunate that our imaging companies have embraced structural heart disease, both for TEE as well as intracardiac echo, and we're able to do a lot of things now with ICE that we could only do with TE alone in the past. So I will leave CT. Mo is chomping at the bit, so I will leave the discussion about CT. But CT obviously for procedural planning, as we've already heard a little bit today, has been incredibly important as well.
Thanks, Costa. I do have one question, if we have time, Devi or Jason. I mean, in this field, how the future, how do you see in terms of patient selection? Which device do we use? If we have all the devices available, which one fits? It's like kind of going to the TAVR world. Now we have a variety. What are your thoughts about it?
So I'll take that question first. It's a great question. I do believe that it's, I like different flavors of ice cream, so I'm going to keep it that way. But having said that, I do think that the appendage is so variable. There's going to be a comfort level for each operator. There are going to be a lot of factors that play a role. To me, it's going to be what's on my Christmas list is a device that I don't have to think about the anatomy. I can choose the same device every time and get the good result with no leaks, and now worry about screening or having surveillance screen in the future for DRT. If we get to that point, I think I'll have one device. Until then, I'll have multiple.
Yeah, I mean, I agree that the anatomies are so variable, and it's like all of interventional cardiology. The problem is that the technology is evolving so quickly. The minute you come up with an algorithm, there's going to be another option. I mean, both Amulet and Watchman have next generation devices coming. I think steerable sheaths are actually very important for optimal outcomes, and we had that for a while with Amulet. Not right now. I think when Watchman has their steerable sheath out, it's going to make a big difference, and it will allow you to treat better. I think we can treat every appendage now almost, but we want to treat them optimally. We want to really and we haven't. That's something we haven't really focused on, is the technique. It's a bit of a commodity. We put the device in, and we just see the result. I think there's benefit to optimal deployment, and that's, I think, an area where we're going to really be able to make a big improvement in.
So, I mean, actually, I might address in my presentation, there is a lot about imaging and different imaging techniques. So, thank you very much. And Paul, thank you, don't see him. Thank you for inviting me, and it's an absolute pleasure to be here. I'm an imager from NYU, so it's the ultimate closure case, and it's truly the ultimate case, probably the most unique that I have seen. So these are my disclosures. And of course, we'll start with the case presentation. 85-year-old man with one history of recurrent TIAs and embolic strokes. So referred to our structural program for PFO closure. Yes, I mean, you heard it. This is left atrial appendage closure session, but this patient really came for PFO closure, 85-year-old. So this is medical history: coronary disease, ischemic cardiomyopathy, and permanent atrial fibrillation. So there's a couple of revascularization by the ICD, and then, as I was reviewing this, for a heart that is actually, he had the left atrial appendage closure already with a classic device, 2.5, 7 years ago at an outside institution. Of course, it's outside institution, huh? Which is, I'm not making up, it's truly, okay? So as we always do, so structural heart team is requested that we review this outside TE, which I'll show you, and to confirm the presence of PFO before we proceed with PFO closure. Okay, so I'll show you. It's a very nice injection. It's just not, it's a wrong view, but you don't see the PFO itself, but there are a few bubbles. But what can I say? There is likely PFO with a modest right to left shunt, but you can immediately say, what's the wisdom truly considering PFO closure in somebody who is 85 years old with a competing risk for stroke? So, and I don't have the imaging details of this procedure 7 years ago. Even the company didn't have the best information, at that time. But we'll see this, that it was a tough procedure. So they tried 3 devices. They tried with 33, then they tried with 30, and they eventually settled on a 33 device. And all I know that it's the original morphology of the left atrial appendage was the chicken wing. So it's a tough, I mean, it's really 7 years ago. It's tough. So he then has a routine TE 6 weeks follow-up, and I'll paraphrase, what they essentially said, that everything is perfect with the device. Well sealed, no para-device leak, no device-related thrombus, and therefore they stopped the anticoagulation as it should be. And apparently the patient is very happy because the original reason for placement of this device was the recurrent GI bleeds because of history of radiation proctitis. Okay? So now this is T that was asked to review as an imager. And this is, first I will say what I was expected, so that we can see what was seen. Okay, this is what I was expected, okay? So this is, that there is a large device. The device is not canted. There is oxally clear, there is a proper tissue ingrowth, there is echo dense inside the device. Yes, there is a shoulder, there is some no significant para-device leak, there is, a little gutter, but it's okay. And I expected that, the imager was do it at the appropriate Nyquist limit, a low Nyquist limit. Okay, so this is what I was expected. Okay, but this is what I observed. Okay, okay, you can say that, with some imaging experience, you can say, I mean, device is clearly canted into the chicken wing. There is a lack of tissue ingrowth. It's immediately when you see this, that there is no echo density inside the device, you would say, you know, there has to be a leak. You have to prove that there is a leak. Even if you don't see, there is a clearly gutter, and you have no difficulties. You have difficulty seeing because the Nyquist limit is appropriately high. But even that, you can say that this is not an optimal placement of a device, okay? And then, you know, we'll do CT. This is in a 3D CT, and actually, if I start moving, you can actually see that the fabric is way high, that the portion of the device below the fabric is highly exposed to the gutter, and there's a clear communication between the gutter and the device. So maybe this is related somehow for his post-device recurrent TIAs and embolic strokes. Okay, we can do it at 2D CT. All of this, you still see that a gutter and a leak, but what's most important, and it's actually see that the part device, not only that the iodine contrast goes into the device, but this part it doesn't, which is clearly either stasis, sludge, or thrombus, and maybe was related to this history of recurrent strokes. So then we do CT. This is maximum diameters of the gutter. It's a 25 by 15, but you know that's about 1 to 2 millimeters larger than you would see on echocardiography. And then, so every advantage of CT that essentially we can simulate TE. Now the answer to the question, what this, and remember these patients are atrial fibrillation, so most of them have already had AFib ablation or thought about, so they already have a CT. So we can leverage that CT to have these images that are simulated 0, 45, 90, and 135. We do this for every study. I mean, my colleague Alan Weinberg, who is really a very talented imager, he taught me how to do this, and I'll just show you 0 degrees. I mean, there is a clearly mini appendage that it's left, and the device. So the clinical challenge, you know, here's recurrent TIA, embolic strokes, and malpositioned Watchman, classic. So what should we do next? Medical management, device coiling, another closure device, or surgical closure? And I have a little GIF. It's nice. I can think. Okay, okay. So here's the panel. What should we do? Maybe we did completely wrong thing. Huh? I don't know. You have to control the time. You control the time.
Well, I think, you know, with the 85-year-olds, if they're okay with surgical closure, I'll go that way. Otherwise, I'll try another closure device. Either take it out of...
device, huh?
Yep.
Yeah, it's 85. He's already had, remember, cabbage. That'll be really serious. Okay, so this is what we did. Okay, so this is, we did another device closure. So this is pre-procedural imaging. I mean, this is now, if you put a layer Nyquist limit, this is a poor person's contrast. You can clearly see there is a wide communication with the device. A low Nyquist limit, and then, you know, if you did, this is a standard 45 to 135, which we do all the implants in this primary view. You can see the fabric, how it's exposed, everything. And then we do a 3D. This is always standard unfast view of the left atrial appendage, and you see there is a large crescentic gutter that's clear communication into the remainder of the left atrial appendage, and you can render it differently to see it better. And then you see we did, this is, we recognize there is a mini appendage, and this 4-stage measurements, you can see what device we chose to do that. And you see that it's between 13 and 16 millimeters. I can't say that we have a direct knowledge exactly how to size it. I mean, realistically, see, it's very shallow at 135. So we said maybe we'll try with the smallest device. So it's a 16 millimeter device, and then this is intraprocedural imaging. So this is started with the transeptal. We always do this short axis anteroposterior, bicaval infrasuperior, but then you will see I could not find it. It's saying actually, you have actually, because of the rotated heart, you have to do rotation to do it the mid transeptal. And actually you can see it even in fluoroscopy. Usually we do it in ariocaudal view, but this is elaiocaudal view, which is required, and you see injection of iodinated contrast that is clearly confirms that there is a leak into the Watchman. We are in the gutter of the device. And now we will just guide the procedure. You see at 135, you see nice trajectory of the delivery sheath, a little bit on the 45 tougher, but if you look at the 135, look at the 3D, you see that we are really in the crescentic. And just for comparison, this is 135 axis, this is 45 axis, so we can follow in both 2 and 3D. And then we proceed with the ball, which is a part, and then eventually deploy lobe and the disc just behind. So it seems to be okay. And then we will look at the 3D. It seems that covering the disc is covering the entire gutter. And then we do injection, confirm with the injection that it's really sealed the left atrial appendage. So there is no more leak. And a post-release, you see, it's 135, looks stable device is standing there. So this is, again, in 135 in color. So it slicks, you're closed, and pretty good pictures, and the 3D sits down. And this is a Watchman, really, of this. So it's really nice. What did I learn from this? So that really we have to spread the knowledge into the community of recognizing what's a normal placement of the device. It's truly, this is really lack of really us. And then the other is multimodality imaging, really the power of not only echocardiography, but CT imaging. And finally, that this is, there is, as you pointed out, there are advanced techniques how to do that. And I would just say this happens to be one device. We have done the opposite as well. So this is not a statement about one or the other device. So I just want to be clear. And thanks to, this is a collective work, teamwork. So I hope you enjoyed the case. Thank you very much.
That was a great case. And the delivery, I would say, was professional. Like, you had us hanging on this edge of our seat, like, what is going to happen? Please, please, who did it? But two questions was, first of all, did you have any follow-up imaging? Because one concern would be it's a very irregular kind of space there, right?
Absolutely.
And so are we getting complete sealing with the amulet?
All I can tell that we just did it about a week and a half ago. So I'll tell you next year maybe.
And will it be CT or T that you will do? Because it depends on how much you want to see, actually.
No, we'll see. I mean, we'll actually see if that's probably that is at the edge because they're very crescentic, probably at the edge. And there is actually a suggestion of on a CT that are just a tiny two, particularly with that true view. You can actually see the, but I can't, there is no.
Will you do CT or T?
We'll do probably T, but CT might
look good on
but
T.
T is definitely will be done.
And the other little comment was, I mean, I don't remember, but it's certainly possible that device canted, you know,
oh, definitely.
like within,
I mean, the original device.
months after, it might have healed in a way that it just kind of tucked into the wing.
Absolutely.
That's probably what happened.
Yeah,
it's so rigid.
Yeah,
you know,
almost positive that what typically happens with, that's why the chicken morphology is a tough morphology. The even original placement of a Watchman device can actually later, we have seen all of that, the cans into the.
So why an amulet, not a second Watchman device? How did you decide?
I didn't, I just, I'm the imager, so I'll say that, but I don't think that it would have been, because the advantage of amulet is really with the disc, that there is an additional disc on top of that, so that the lobe provides the seal and additional,
Sitting on top of a irregular device.
Yeah.
I guess there's not enough depth as well for
Yeah,
another
the
Watchman
depth will
device
be
in
also,
there. It won't have anchors, and you have to worry about stability.
Yeah.
With that kind of a tilted device, almost always we'll put a lobe behind the tilted device and then use the disc as the seal mechanism.
Yeah.
I do have a question for you. With the patient having a TI history, did you guys use any cerebral embolic protection, or
No.
is that no? Okay.
We didn't. We did. We routinely don't use cerebral protection.
Did you close his fake PFO?
Huh? No, I've been here with it, like about 85-year-old. Yeah. But also, I think that not only that this device, we have seen the device of vascular plug closures, PDA closures devices. There are different devices, not necessarily that were originally designed for Watchman, for left atrial appendage closure are used in this space. Is that, would you?
Yeah, I think that one of the biggest points to me is as an implanter when they come back, the imaging part, because sometimes we'll do TE and there's always all this data that talks about CT being more sensitive, but if you look at the device and there's echolucency, there has got to be a leak.
That's exactly, that was my point, is really, that's why I included what was expected to be, that everybody sees this echo density inside ingrowth. That's the normal finding. When you don't see that, you have to find the leak, even if you don't see it immediately.
Yeah.
That's a fantastic case. And moving on to Dr. Jason Rogers, who's actually going to be presenting a case of left atrial appendage closure device misfit.
Okay. And I have a similarly impressive case if you're here tomorrow on a Hail Mary Watchman case. But this is another interesting case, and it's called LAAC device Misfit. I guess people can be misfits, but devices can be misfits as well. So this is an 80-year-old gentleman with paroxysmal AFib, prior bypass, had, pretty significant intracranial bleeding, subdural hematomas requiring bilateral craniotomies, spontaneous, while taking aspirin only. And this was about 12 years ago. And when I saw him in 2011, he was back on daily aspirin, and he had been referred for a Watchman. At that time, we did not have commercial approval for amulets. It was Watchman Flex was the commercially available device, and our plan would be DAPT post-implant due to bleeding risk. So this patient did not have a CT due to renal insufficiency, and we did a T on the table, and this is what we saw. So what's unique about this appendage is the ostium is very tiny. It's almost like he had attempted surgical closure in the past and maybe reconstituted, although there was no record of that. I think he just had a very calcified mitral annulus that kind of extended a little bit into the ostium. So what we're measuring is the ostium here, maybe 11, 12 millimeters, but the actual neck is much, much smaller. And, so we said, well, we can try to do this, and this is the initial appendogram. Now, the pigtail would not actually pass into the appendage. It just wouldn't go. So I actually had to wire the appendage like with a J-wire first, and then track the pigtail into the appendage. And this was the initial appendogram. And I couldn't really get a sense of how big it was. And it was also hard to advance the guide into the appendage. It was very tiny ostium. So with some rotation and kind of gentle manipulation, we were able to get the guide up into the appendage, and this is the image that we saw here. So it's basically, like you're corking a coronary artery and an osteal lesion. I mean, there's no backflow of contrast almost at all. I'm just doing a very gentle puff, and the Watchman guide itself is essentially occlusive. So the question is, how would you proceed? So maybe we'll just pause and say, what would you do?
I mean, at least from the anatomy that I'm seeing, I don't see, at least if you didn't have amulet, I don't see a Watchman going in there. Maybe a different kind of occlusive device.
You're going to see it.
I'm sure you can make
Yeah.
anything fit in there. But,
Yeah.
I would look for another occlusive device.
Yeah. But a
other
few
than
years
the-
ago, we had a very similar case that was closed with the smallest Watchman.
Yeah. So, but you would use, now you would use amulet. Rahul, you've used a lot of amulet.
Yeah, I would certainly use amulet here. Did you consider, getting a little fancy with some coils and vascular plugs? And
Yeah, or maybe like a small, like ASD occluder or something like that. That definitely crossed our mind, but given just trying to stay on label and doing what we thought we would attempt the Watchman initially. Yes.
Were you worried you were going to be pushing against somebody else's curl lanes? Because that is a surgical closure. Somebody tried to close his.
It felt that way.
100%. That's what happened.
But I thought all surgical appendage closure is complete.
Correct.
So the-
Remember, 40% of the time, and it depends on what technique we use at the time of surgery, whether it's a double linear or circumferential, about 40% of time overall. Of course, when you use something external device like the atrial, it's 100% unless you screw it up. But if it's circumferential, it's almost 60% of the time it doesn't. I would say that whoever did this tried to do a linear closure and it split open. So I think you're going to be fighting some pro lanes when you go in there. That's just my thought.
Right.
One of the other times, Jason, is when we do LAA isolation, which I'm the only one in this room probably that does it, is when you actually try to isolate the appendage, they can get stenosed at the ostium.
Osteal stenosis. Okay. So we went ahead with a Flex, and of course Flex had been newly approved at this point, and it's very conformable. It's a great device, and we thought, okay, well this could be good. So I initially just tried to land it just right at the ostium. You can actually see the calcium. There's this hunk of calcium right here. That's actually right at the ostium of the appendage right here. So it's this calcified nodule, maybe post-surgical, but this was the initial appearance. And so you can see it's right in the neck of the ostium. And this is the puff. So, I mean, I didn't really like it because what I didn't like about it was the fact that this hub is just sticking out here like the Eiffel Tower out of the ostium here. So you have this projection, and when we release it's really going to stick out. So, you know, we decided to redeploy it in a way that might, you know, fill this space a little better. So went ahead and retreated. This is what it looked like on TEE. Now, you don't really see the fabric very well, but there is the hub which extends to about here, and then there's this kind of tent-like teepee of fabric that would be coming and sticking straight up. And I just felt like that wasn't going to be ideal. So we recaptured, and then this was the second deployment. So now we're kind of creating this peanut shape with the ostium right in the center, and this thing is sticking out like this. And this is what it looked like on TE. So, I mean, I thought it looked better. Certainly seems to fill the space better. There are some two small gutters on either side, but that may be more similar to what we see with Watchman. We often see these small gutters, we call them, on either side of the device. And I just like the fact that it seemed to fill the space better and be less kind of protuberant. This was our.
So Jason, can I ask?
Yeah.
I mean, certainly no question about compression, but were you nervous about the validity of your tug test, or were you quite sure that the distal part of the peanut was well anchored, and whatever that stenosis was going to keep it there?
Right. I felt it was, and that's right. That was the other thing about the first deployment, was that the anchors were not engaged at all, and I was worried that it would watermelon seed back into the appendage, you know, with the first deployment position. With this position, the anchors are about halfway down here and then a little bit farther back as well. So I wasn't worried about it squirting out anymore at this point. It was very solid. So I would say usually, you know, you can get a Watchman to sit pretty well, and it looks nice. This was just a unique appearance. I never really had a case quite this compressed before, and a very small appendage really needs almost a dedicated device. 6 weeks, we brought the patient back for TEE, and this was what was interesting about this case. So this was the 90-degree, and you can see this basically large amount of thrombus covering the device. Here's the hub, the device, but it's very layered, it's very smooth, and this is what it looks like here. Oh. So, you know, patients on DAPT, they can't, you know, really take anticoagulation because they've had these craniotomies, so what would you guys do? I mean, he's fine. He's no symptoms at all.
I'd leave it alone. I mean, if you try and suck that out or do something, you're more likely to cause emboli, and it's probably just going to reform anyway. So if it has that smooth, laminated appearance, I'd leave it alone.
Would you reimage?
I mean, will it change your management? Well, it'll probably just show maybe it's just more organized, hopefully more capped. So no.
To me, it seems like it's going around the left atrium wall.
It's very...
Looks like it. I'm not sure whether doing cardiac CT might see the extent of it.
I didn't get a CT on this one,
Looks
but there is I do have a 3D TE, and if you look at it, it just looks like smooth. Like it's just smooth. Looks like atrial wall.
Let it be.
Yeah, smooth thrombus. It's very, what do we call it? Layered thrombus.
So can I ask you, Jason, I mean, this is an EP asking, so would you actually look for like Plavix resistance and stuff like that and hypercoagulable workup when you see stuff like this? Do you attribute it to the DAPT, or do you attribute it to the patient?
Yeah, we don't. That's an interesting question. I mean, that has been explored extensively in the PCI literature, and turns out it doesn't make a difference.
You do know the term smooth thrombus is an oxymoron. If you ever look at that in real life, it is terrifying on the inside.
I mean, we do see this not uncommonly after LAO closure, and maybe smaller versions of this, but you see little areas of where little divots. It's almost like you applied like some putty to an area to kind of smooth it over. But well, we did what you said, Rahul. We left it alone because I mean it looked like the embolic potential here was low, and he's on DAPT, and we just re-imaged him at 4 months while on DAPT, and we had a discussion with him as well, and he really didn't want to take anticoagulation. I think that was just not an option. So this was the CT here at 4 months, and you can see that the thrombus is there, and it's layered over the device. But again, it's very smooth, and it's almost like it seems like he's generated a new kind of neoendocardium over the device. So and the appendage is sealed. There is no contrast in the appendage. So this was the final result, and so we left him on DAP for additional 6 months, and then he went to single antiplatelet therapy. This was 2 years ago, and he's doing fine to this day. So that was the case. Thank you.
Quick question for you, Jason.
With recent evidence, would you, I know this was an older case, but would you have chosen low-dose DOAC instead of DAP for this patient now?
So my understanding of low-dose DOAC is that you have less anticoagulant effect, but the same bleeding risk in a way. So we may be exposing the patient to the same bleeding risk, but not protecting them as much. So I didn't really consider that. I know that could be an option, but I don't think we have enough data to say that was the right choice.
So I have a question for you, Jason. Why do you think this happened? Is it those big gutters? Were they truly gutters, or was it communication through and through, or?
Yeah, absolutely. It's an anatomy and a mechanical issue. Just a lot of turbulent flow around the device, and that's one of the points of AML is that you create a smooth disc, something that's being washed all the time. That's why we want, and we talked about that earlier. Getting optimal deployment, even with Watchman as well, is so important, because you want to have it flush. You want to have it not sticking out too much. Big shoulders. Anything that creates turbulence is probably a setup for this. So,
but maybe may I comment? So my understanding that of the hundreds and hundreds of these that we have seen image, that it's really clot formation is threaded insert related, that starts around the threaded insert on the device. And the reason why I redesigned from a classic 2.5 to a flex was to hide the threaded insert as much as in. And I was just wondering here, because of this peanut formation, didn't actually expose the threaded insert more to the bloodstream than you would usually see.
it can form there. It does form other places too, outside of the threaded insert. So the big places in the gutters, you'll see that in those areas. So it's not just the threaded insert.
It'll be interesting to see what Flex Pro brings with the non-thrombogenic coating.
Great case. And moving.
Thanks.
Great case. And moving on to the next ultimate closure case, we have Cliff Kavinsky, who will be talking to us on catheter choice and left atrial appendage closure success.
Thank you so much. I'll try and stay on time. I'm bringing a couple cases that you might find interesting. I know Paul always relies on me to bring my my worst nightmares here, so I'll continue that concept. 65-year-old, cervical cancer, status post-surgical resection, extensive adjuvant abdominal radiation, paroxysmal atrial fibrillation, CHA+DS score of 5, HAS-BLAD score of 5, recurrent GI bleeding, prior attempt at a left atrial appendage occlusion aborted due to fibrotic radiation-induced bilateral iliac vein occlusions. So patient came to see us at our Rush Center for Congenital Structural Heart Disease, desiring some sort of address to her left atrial appendage. After we discussed it extensively, it was our decision to proceed with a transhepatic approach for selective left atrial appendage occlusion. And here's some of the images from that. In the left upper panel, you see us. This is the micropuncture needle approaching from the mid-axillary line. And in B, this is we did this with biplane in our hybrid lab. The needle has to be directed anterior to the spine. And then I'll show you after we punctured, this is the angiogram showing the micropuncture sheath in the hepatic vein, both in the AP and lateral projection. Now if I can go back. And then what you see here, I've labeled these images. E is our sheath, our SL1 sheath, as it moves up through the liver, up into the right atrium and engages the interatrial septum. It's our transseptal equipment. What I had to do, though, because when the transeptal equipment came up into the right atrium, it was immediately in contact with the interatrial septum. I actually had to take it back and take the bend off the needle, off the SL1 to make it straighter so it engaged better. And in panel F, you see what we did was put in a 33 millimeter Watchman device, which sat very well. And then in G, you'll see, I'm going to take this forward. And what you can see is we're deploying coils to close our hepatic puncture. We put in 2 coils. And with that, we took the sheath out and had good hemostasis. And she was discharged 48 hours later. Follow-up TE showed excellent seal, no residual leak, and she was taken off all oral anticoagulants. So I show this case because it's a novel approach. I don't know if I've seen many other people do transhepatic approaches for left atrial appendage occlusion. I don't know, has anyone else in the audience done this? Paul?
So we'll,
Go ahead.
No,
So
I'm
we'll
just so
actually
stunned
do-
I couldn't speak.
I mean, this is amazing.
Yeah.
So how do you know where to go? I mean, how do you know where to, and then, like, where did you put your 032 wire up into the SVC?
So actually puncturing into the liver is relatively safe. It's coming out that's the problem. So when you puncture in, you go in the mid-axillary line below the rib, and you use biplane, and you got to direct it up towards the heart, and you got to be anterior to the spine on the lateral view. And then you just carefully advance your needle, aspirating until you get like a venous return. And then you take a soft wire and push it through and see if you go into the into the hepatic vein.
So you're not doing this under ultrasound guidance. You're doing this just.
This is fluoro. This is fluoro driven. All fluoro driven.
No.
You know, maybe. I don't know. I just, you know, how are you going to get the ultrasound to penetrate deep into the liver like that? I'm not sure.
So I was going to
You
ask
almost
if
have
you would
to
go
do it
IJ,
reverse.
if you would go IJ with an ICE catheter, and use the ICE catheter to kind of give you at least directionality as to where the IVC were.
You know, I'll do that on my next case.
Okay.
So that's kind of what we do. When we have transhepatic AF ablations, we'll put ice through the IJ and put the ice in the IVC, and you can clearly see the vein.
You
so
can.
Yeah, so it's an ultrasound-guided stick from inside. And then it's almost reverse imaging. We used to actually just send it to CT and have IR IR do it. You know, and the patient comes back with the 16 French sheath. It's the best case ever.
That is,
You don't have to worry about it.
This is very impressive. Why not lariat?
Why what?
Lariat instead.
Yeah, I mean, we still need transeptal access, right? So,
It's almost
yeah,
like-
we were doing lariat at the, you know, I could have done lariat.
You could have. I mean, I guess it'll have to be a AtriClip or a minimally invasive AtriClip more than
So
a lariat.
lariat is kind of the last choice, right?
Why not a thoracoscopic, just AtriClip from the outside surgically? I mean, as a surgeon, I was getting a drink, I came back, and I peed myself with that anxiety when when I figured out what you're doing, like, what?
So she's a pretty sick lady. She had a lot of radiation,
Okay.
a lot of abdominal radiation. So she was, you know, she was not going to get another operation.
We do, not a huge amount, but just tiny thoracoscopic AtriClips for this situation. We've had good luck with it.
Well, I have a second case I wanted to get through
Yeah.
in my last 2.5 minutes. 77-year-old, permanent AF and recurrent GI bleeding on an oral anticoagulant, evaluated in outside hospital, declined due to the small size of the left atrial appendage. Taken for left atrial appendage occlusion at a second institution, was aborted secondary to small size, below the minimum diameter for a Watchman device, which was the only device on the market at that point. Oz measuring 8 to 10 millimeters. After discussion was made, this had to proceed with closure of the appendage using a vascular plug. Here's our initial images. You can see the appendage there, and there's our measurement, measuring about 10 millimeters across and 14 millimeters deep. And here's CT scan, if you like CT scan, showing it about 9.7 millimeters across the Oz. Are you happy there? Okay, so here we are. We did a transeptal puncture, versicross, 8.5 French Visigo. We were out of the Agilis sheaths. woolly wire to access the left atrial appendage, 6 French multi-purpose catheter, advanced in. There's the image showing you the appendage. It's a small one. And then here we are, we put in a Rosen wire through the multi-purpose, tracked in a 6 French multi-purpose guide catheter, 12 millimeter AVP2. Now, this is where it was a problem, because the fellow was doing this. I know we always blame the fellow, but it's my fault. I didn't check to make sure that the plug was still connected, properly connected to the delivery cable. And so when we pushed the device out, it came out disconnected. So it was there, and it was not going to go anywhere else. That was where it was going to be. Now, it was too deep. Well, you could snare that. It's there, and it's not going to go anywhere, but it's a little deep. But it is covering all the trabeculations. So I would ask the panel, I mean, what would you do? You only got about 2 to 3 more millimeters of space in front of it. So are we happy, or do we try something else?
I'd try snaring it, giving it a little tug, and bring it forward a couple of millimeters.
It looks like the true ostium is much smaller, like at least 10 millimeters away. Well, maybe if you could point to where you think the ostium is. I mean, what's the, I guess the opening to the appendage is?
You know, somewhere around here.
Down below, like that little.
So, you know, you're right. We could have tried snaring it, pulling it. That's actually a good thought. I didn't do that. I was really pissed. Because, you know, they always tell you, you always check to make sure your device is connected to the cable. You tug on it. I didn't do any of that. And this is the second time this has happened to me. Anyway, here's the final echo images with the cable still, with the delivery sheath still there. And, you know, the important point is for all us doing structural heart disease, there are some basic concepts. You have to understand your equipment. You have to understand your anatomy. You have to be facile at procedural imaging and managing vascular access. And this is so important for safe and efficacious execution of your procedures. And you got to be able to recognize and treat your complications. So these are the basic tenets of structural intervention. With that, thank you.
Can I just go back to the first of his cases? So how does IR close this? So you send them off, they come back with a 16 French sheath through the liver.
Yep.
And then you do your thing, and then when they take it out, he looks like he puts coils. But
So
what do they do? What
They'll
do they do?
foam. They have some kind of gel foam closure that they do. And the patient goes, if they get the gel foam, they most of the time go home the same day. I've not seen them do coils. I probably have to ask them about it, but
I use coils and gel foam.
gel foam, yeah.
And it's inside the hepatic vein or outside the hepatic vein?
No, you're
It's kind of outside.
outside.
Yeah,
outside.
It's outside.
So it's
yeah.
kind of like just essentially packing on top
It's
of the
almost a
hepatic vein?
Vascade version.
So that is the trickiest part, because if you don't get it just right, then the patient starts to bleed and you end up with a big problem.
Sounds like we need to partner with our IRs people a little bit more.
What about the-
What about transjugular, transseptal to do Watchman? Would that have been an easier
You know,
way?
I've not done transeptals from the jugular approach. I don't know. Have you
You
done that?
could. I think the only time the transjugular is better is when you have a really inferior ostium, but a superiorly directed appendage where you can come around and go up. Sometimes if you that's the only time I've done is a transjugular is came transeptal, came really low, but it was the atrium was so enlarged that the appendage was so low. And so you almost had to come from here. And we ended up using a steerable cryo balloon sheath, rigged it up because you have to have a steerable sheath to put it. Otherwise, you can't use a regular
I could see maybe doing with a steerable sheet.
steerable sheath. Yeah.
But not with standard
Yeah.
equipment.
I think once the
it's
true steer is out, I think it's possible with the steerable amulet sheath. Maybe it's possible, but without a steerable sheath, it's not easy.
Amazing cases. So our next presenter is Nishtha Sodhi to talk about a new clinical boundary crossed with left atrial appendage closure.
I think Cliff stole the show, really. I don't know what more ultimate case we can really have after that, but thanks, Paul, and everyone for having me. So we'll kind of get into a next case here. This is sort of a more traditional, I would say, introduction and case setup here. This was a 87-year-old lady with prior history of hypertension, CKD, AFib, with an elevated CHADS-2 VAS score of 4 and a HAS-led score of 5, who was previously anticoagulated, and now with recurrent falls due to gait instability. She also has history of esophageal strictures for which she was unable to have a TE passed, and this was attempted multiple times with no success, as well as a history of anesthesia-associated hospital delirium. So she was referred for left atrial appendage closure, and as a team, we discussed her and felt that in this particular instance, she was probably best suited for nurse-led conscious sedation with ICE imaging. Now, this is a very straightforward case, so we'll kind of flip through the images. This was the transeptal performed. Measurements were made with the ostium, and a 27-millimeter Watchman device was placed, and no issues, no delirium or anything, and she was sort of discharged home later that same day. I just kind of used this case to really introduce kind of what Devi had brought up earlier with the ICE LAA study that was published and presented earlier this year. And for those that don't know, this was the prospective multi-center study from July 2020 through August 2021 with 7 centers across Europe with 100 patients enrolled. Pre-planning was performed with either CT or TEE within 7 days prior to their appendage closure procedure, and intraprocedural ICE was carried out from the left atrium. The primary endpoint that they set for this study was the rate of leak greater than 5 millimeters at 45 days post-implant, as adjudicated by the Echo Core Lab. And you can see here that they had excellent procedural outcomes. The device success was performed in all cases, as well as technical success achieved in all cases. Their procedural success, which they defined as device success plus any absence of in-hospital device-related complications, was 96, and the 4 that were not part of that 100 were due to bleeding. And you can see that there was no conversion to TE as well during the case. The primary endpoint was met. None of the patients had more than 5 millimeters of leak at 45 days, and excellent clinical outcomes at 45 days as well. So I think, we have a very esteemed panel. I think mostly what I wanted to do with this case in time, as Dr. Nair and Muhamed also alluded to earlier, was really kind of get into the workflow as we start incorporating ICE into this procedure and possibly even eliminating it altogether from the procedure itself. Some of the procedural pearls, of course, as we've learned about in this session, include, of course, the importance of pre-procedural planning with imaging. And Muhamed very nicely showed that with his cases and the reconstructions that we can do to really just set us up for success, not only from a technical standpoint, but also from a device selection standpoint prior to the patient even coming into the cath lab. Other techniques that have been, of course, described are double venous stick to minimize vascular access complications, and then, of course, a single transeptal puncture site for both the ICE delivery system as well as the appendage delivery system. We've gone through this earlier in the session today, but sort of the key kind of views that we're looking for in ICE, including the mid-left atrium view, the left upper pulmonary view, as well as the supramitral view here. And so with that, I really I think that we have such an esteemed panel, and I think that we've had some awesome cases. I don't really think we can top Cliff's here. And so I'm just kind of curious for the panel to kind of share their workflow for these particular cases. And I think, earlier yesterday we were talking one session with sort of limited resources all around. It's fantastic working with our anesthesia colleagues, but as they're being pulled into more and more structural cases, how do we sort of, as a system, tackle on these cases, knowing that there are limited slots and just limited availability of all resources? So with that, I'll kind of tee it up, and maybe you guys can go down
Devi, do you want to start
your
your workflow?
Start. So I'll definitely say that ICE is definitely a great addition to the imaging portfolio that we have. It gives you flexibility in doing cases, and I love having my TE imager in the room because there's a second set of eyes, and there's some talking going on. It's not, I don't know, just feels better. But eyes definitely, you have somebody to talk to. I'm usually an EP alone in the room, so I like to have somebody in the room. So thank you. There you go. And so even when we use eyes, we've actually moved on to using more and more 4D eyes rather than 2D. And when we use 4D eyes, we still have our imaging colleagues in there. It just happens, I heard Nadira say yesterday, now it's my turn to get them the image. That's the only difference. And it is true. I get the image and I stand back and they do all their fancy manipulations and give me the best images. But eyes definitely has changed the workflow. You're right, you have to get double axis. I usually slide it across the same transeptal hole. But the key when you're using eyes is the images that I provide are the only ones the imager gets to play with. So it's very important to know how to get the eyes catheter into these different positions to get the right images. And I think that's the learning curve. Despite the fact that we talk about this, I said yesterday, there's only about 10% of implanters that use eyes in this country. So there's definitely a steep learning curve to it, and there's more adoption that needs to happen.
So I would say that the biggest, it's truly the use of eyes truly changed the procedure by just sort of like the way we did it with TAVR. We started with the endotracheal intubation, TEE, and then we switched to moderate sedation and transthoracic echocardiography, and essentially we are trying to replicate the same workflow now with left atrial appendage closure. Instead of transthoracic, we use eyes imaging, which will then obviate the need for endotracheal intubation, general anesthesia, or even professional anesthesiologist in the field. But what you pointed out, this is really for 2D eyes imaging. This is a 2D eye imaging, and I would say that's really a CT pre-sizing, is because really you don't have a standard views. And even with the 3D eyes, there are actually only 3 views that you can generate, which is equivalent 45, 90, 135. You can't have a 0, but luckily 0 is the least important because there is no anatomic marker. And it's probably maybe just one thing if I can say that the biggest mistake that we made when we originally named these views, it's 0, 45, 90, and it's really we should have had anatomic markers, because even in a regular person, these you can sometimes have a 60, and now when we have a 3D eyes, we then comes minus 45 is equivalent to 45. That's like a mind-boggling, and that we really have to come up with the names for these, whether this is major axis, minor axis, and something like that, that would really help all of us to do.
Let's make a quick comment. So I think ICE is great, and we're in the early stages at our institution for LAAO. So we're actually doing TE to start the case, to clear the appendage, and then we're shutting it down and just switching and trying to do as much of the case, if not all the case, with ICE until we get to the point that we're very comfortable. So at the end, basically, I'll double check everything with TE. We're okay, good to go. But there's definitely a learning curve. I see when I do this with my ICs, it's one way. When I do it with my EPs, it's a little bit different way. They have more familiarity with ICE, I think as expected. But what I want to just comment on is that none of this should come at the expense of procedural results. This is a safe procedure. It's a procedure that works pretty well, and really we want to be careful that if you're not seeing something, you don't just assume that it's probably okay. We really want to make sure we don't have leaks, that the device is where it should be. So that's kind of, that's what I would add. Because with echo, with good echo, this is very easy. You could see these things very, very easily, especially with just the new tools that we have in echocardiography. So.
Agree with Costa. And just to your point, I think, like you mentioned, 10%. Huge learning curve. I completely agree. It was learning curve for me too as an imager. And so for these, I think, the other thing that we can, use is I think the mini TE, which I think some of the vendors now have put out. I know GE and obviously Philips as well. And I think there's a role there in moderate sedation. Putting down the mini TE, I tried it. It's easy, it's small, and then anesthesia can give moderate sedation, and it's really super easy. And I think there's also a reduced risk of aspiration if you position them well. So that's, I think, another way. And they do absolutely the same imaging, 3D, 3D MPR, everything, and color equivalent to your TE. So I think that's something, that could be used as well.
Nishtha, I just want to make a workflow comment. I think it was really important. One of your slides says nurse-led anesthesia teams, and I think that's fantastic. One of our problems, and probably everybody's problems, is workflow, getting the right MD, imager, cardiologist, anesthesiologist to the right lab at the right time on the right day, and that limits our work and the ability. Yeah, ICE is great and so on like that, and we'll learn how to do it, but the ability of not having to have general anesthesia and a particular image there at time and can increase our workflow.
Yeah, the best thing about ICE is there's no GA or TE, and the worst thing about ICE is there's no GA and no T. So, yeah, I mean, from an operator standpoint, there's nothing better than having a patient under GA and having a T machine, and it makes you do. So ICE is definitely technically more challenging, right? I mean, our procedure times are much longer. You know, we can probably do 2 or 3, if everything else were equal, right? We'd be able to do 2 or 3 GA in the same time it takes us to do 1 ICE, you know. But, you know, there's maybe, you know, faster recovery, scheduling issues and everything. So, you know, it's a process where it's certainly the future. It's where we're headed. No reimbursement for it, right, currently. So, but it's where we're headed. I acknowledge that.
Terrific. Thank you, Nishtha. Great. And I couldn't think of anyone better to bring it home with our last case. Devi's back up with an innovative technique in left atrial appendage closure.
Oh, well, mine, thanks, Rahul. Mine's not a challenging case. I'm just going to show maybe a more innovative technique, and I've got some fascinating minds here that might want to talk about it as well. So I'd like to introduce the laminar technology, which is, this is my disclosures. So the laminar system is here's the animation to it. It's a rotational LAA closure system where you have this little ball that's delivered through a steerable sheath. You pretty much rotate that appendage. I'll tell you about 3 years ago when Steve showed me this video, I clinched as an EP thinking, what in the world? And from that day on, I've been following it very carefully, and you can see it has there's two balls. There's a 12 millimeter and a 16, probably more sizes coming in the future, but the key is that small exposed surface area. You can see the Watchman device and the amulet device sitting right next to the lock of the laminar that's going to be exposed on the appendage side, or the atrial side, and then the delivery system, which as an EP, I know for you guys this is not cool, but to have a stabilizer, come on, it was cool. So I want to put it that way. So here's, I'll show you one of the cases from the early feasibility study. So currently the laminar trial is in early feasibility, and then hopefully for a pivotal trial coming soon. So here's the appendage that we were dealing with, and I'll kind of play it all simultaneously. You can see it's a chicken wing. I routinely do my angiograms with a VersaCross wire, so it's a 24 millimeter loop, so it measured 18 by 14, so relatively smaller side, but a decent chicken wing appendage cleared of thrombus. You can see the three-dimensional look as well. And one of the things that I routinely do is we always implant our devices in the 3D format. So here's the delivery system going up. So I do the standard transeptal with the VersaCross system, and I'm coming here with the 18 French delivery system. It's a steerable system. You can see as we are going up, it's a very smooth transition as you go up. I have the VersaCross wire in the pulmonary vein as I'm exchanging. And then came the first cool toy, which was the stabilizer, which was the first time the EP lab saw the stabilizer. So there is, once the sheath is across, now you're coming in with the ball. So I have the animations playing on the side, but what you're seeing is the stabilizer holding on to the delivery system, and you're unsheathing the ball in the left atrium, in the mid-LA cavity. And once the ball is exposed, you'll see it's a slow advancement of this ball into the left atrial appendage. What I thought was really cool about the system was how I could just take my hands off, do small manipulations, and back off because the stabilizer would hold everything in place. I did not need a scrub. I don't have fellows, so I don't need a scrub to hold anything. Everything was in place. So that was really neat. Once the ball is in place, we'll do an angiogram to make sure that we're in adequate contact, because you want to have that ball in contact with the appendage wall before you start rotating it. So the next step is rotating the appendage. I have the animation going as well. So you'll see it's a slow rotation on the handle, and you're going about, the foot, in this case, we're rotated about 270. And on 3D, you'll see really well how that appendage just kind of completely goes away, which is, again, really fascinating to see. And you know that you have good tissue contact. You can give some contrast check as you're rotating as well to make sure that you are. So you'll see, we'll check with contrast here. And you can see that we have engaged the tissue, not completed the rotation. We'll do some more additional rotation to get it to full occlusion, and then confirm it with an angiogram before we come to the next step. So once I've finished the rotation, we'll do an angiogram here. You can see there's almost near elimination of the left atrial volume with that rotation alone. So the next step is extending the lock, and at that point, you'll see the lock kind of come out here. So again, the animation of how the lock comes out. You're unsheathing the lock out, expose the lock. I'll check again with angiogram to make sure that there is good occlusion before we move the lock forward and lock it. So this is the next step where we move. We have clearly seen that there is very good occlusion, and at this point we are moving the lock forward and I guess attaching it to the ball and locking it in place. And once that is done, I mean, you can still kind of come back if you need to, but once this is done, you are almost in a good place. You can see I have really good occlusion, good seal, nice canting on that lock that tells me that I have good a position. So it's time to release. Here we are getting ready. You can see there's a suture that I just released in the back end here. It's a protective suture. And once that is, once we are in a good place, I'm just kind of rotating that to make sure that we release it. You'll see it come apart, and you'll kind of almost push the sheath forward to just kind of let it off the LA, and you can see that with a really near perfect occlusion and complete elimination of the LAA. So this is an example of LAA that was closed with the laminar system with the post-implant imaging at 45 days, showing the CT showing complete elimination of the appendage. Again, in the EFS study, we'll be doing TEs and CTs. So this is just one of those examples. So in summary, this is a rotational closure system of the appendage where the LA volume is completely eliminated. There's definitely very low surface area exposure to on the LA side for the lock. The closure is really not dependent on the anatomy, except the ostial size, where you have to pick the right size ball. And where there's multiple operators, both ICs and EPs, involved in the EFS trial, looking at safety and efficacy, and hopefully in the pivotal trial pretty soon. Thank you.
That was fantastic, Devi. So Jason, you've had experience with this and you're quite involved. Of all of the features that Devi listed, that address some of the as yet unmet needs in left atrial appendage closure, which of the elements of this new technology do you think are the most exciting for where we're going?
Well, first of all, Devi, thanks for showing that fantastic case. I mean, for me, the most exciting thing was just basically the no leave behind. There's essentially no surface area. So that's the lock, as Devi showed, is 4% the surface area of a conventional occluder. So it heals very rapidly like a bare metal stent. So I think as a clinician, just having that very little leave behind, not worrying about DRT is a big selling point for me. And then also just the complete closure, the final angiogram, seeing the flush closure, almost surgical-like. I mean, this was Steve's concept of having a surgical-like closure to an appendage that would actually, and when you look on the inside, it's flush. There's nothing left behind, and so the team came up with this design.
And for the images on the panel, how much of an advantage is it to you that, in terms of the sizing, it's sort of two sizes, if I'm not mistaken, you're less dependent on the variations and heterogeneity in appendage, whether it's a cauliflower, chicken wing, all of that's effectively irrelevant, right? How much does that play into your affinity towards that device as an imager?
That was one, I think, the beauty about this device. I think that's one of the wish lists that you mentioned during your first keynote talk about this, that it's completely independent of the anatomy. The two sizes, I think you mentioned, is based on is it the ostium width? I just want to, is that right?
Yep. So I guess there's a 12 and a 16. And if I'm right, Jason, there's a smaller ball and a little bigger ball that's probably in the works. But there's a large amount of overlap if you look at the sizing chart, and it really comes down to how much tissue you have to retain, at least from my very vast 6-case experience. That's what I'm telling you. I'll have Steve and Jason probably talk more about it, but the way I understand, I guess it's about how much tissue you have to rotate and how much you're locking in. So any other comments from either?
The mean osteal diameter is what we look at. So
Okay.
within a certain range, we're going to use the 12 millimeter diameter ball, and then in the other range, we use the 16. So that will cover probably 80 to 85% of all appendages.
Yes, absolutely.
And then, we might need something on either end for the tiny ones and the really large ones.
And one last question, sorry, Costa. How deep during intraprocedurally the ball that has to be, when you go in from the TE imaging intraprocedural to guide you guys in? How deep do you have the ball to be? Depending on anatomy, of course, but something I'm just curious about.
I mean, the 12 millimeter ball is 12 millimeter in depth. So it has to touch the back wall for it to engage the appendage. So that's pretty much all the depth it needs.
So, question for you: how hard is it to do? From how coaxial, how well lined up do you have to be? If you're a little bit off, if you're a little bit angled this way or that way, does it matter, or do you have to be literally perfectly,
So
perfectly
I will
lined
say
up and coaxial?
Yeah, that's a great question. The sheath is durable, so you can actually change your coaxiality. One of the cases, we were a little bit off axis when we started. Did not really like the closure, so really just unwound it and put it in a different spot and wound it back. And I will tell you, the first time I unwound it, I might have, called a couple gods in there. But it all. I'm just telling you, this is true. As an EP, winding the appendage it's a pretty big deal in my lab. But it was just, I was just amazed at how easily I was able to unwind it and direct it in a different direction. I do think that you do need to be coaxial, and having a steerable sheath, having the right transeptal is definitely important. Yeah.
Fantastic. Well, I think that brings to a close a wonderful session. It was like a roller coaster of emotions, but it was fantastic. A lot of exciting new therapies and developments, and certainly the way the field is progressing is very exciting. And hopefully all of these improvements in technology and patient selection experience will lead to an improved penetrance into what I think is still a very underpenetrated therapy. So with that, I'll thank all of my esteemed co-panelists and co-moderator and all of you, and of course the presenters. So thank you so much and enjoy the rest of the meeting.